Good afternoon, everyone. So we are going to, hold a second. Officially start the Heidelberg Park session of Glaucoma and Neuro Ophthalmology. So the first presenter is Dr. Kanchan Sharma. Dr. Kanchan, please. She is going to present. Please provide some pen here. Management team.
So should I start?
Yes, please.
So good morning, everyone. I'll be discussing about the incidence of progression in patients with normal tension glaucoma. So normal tension glaucoma is a type of progressive glaucomatic optic neuropathy, and its main difference to primary open-angle glaucoma is that it presents with normal intraocular pressure that is less than 21 millimeters of mercury. Although intraocular pressure is measured within a normal range, the optic disc excavation, the visual field defects are detected. It has been suggested that vascular dysregulation is a primary step in initiating glaucomatous damage in normal tension glaucoma via ocular blood flow instability, affecting the optic nerve and retina by the enhancement of ischemic damage, as well as by promoting the apoptosis of retinal ganglion cells and their axons. Various studies have indicated systemic hypotension as a common risk factor in these patients. Low systemic blood pressure, particularly during night, it reduces the ocular blood flow via reduction in ocular perfusion pressure and contributes as a major risk factor for normal tension glaucoma progression. Additionally, retinal venous pressure is increased in patients with glaucoma, resulting in a lower ocular perfusion pressure. Migraines have been frequently observed in patients with normal tension glaucoma, and various genes like WD repeat containing protein 36, myocilin and optineurin are also considered causative for normal tension glaucoma. So the purpose of the study was to find the incidence of progression in patients with normal tension glaucoma in a tertiary care hospital. Inclusion criteria: all the patients with normal tension glaucoma who have completed follow-up for 5 years, patients with unilateral or bilateral normal tension glaucoma. Exclusion criteria were patients who had earlier received glaucoma surgeries like iridectomy, iridoplasty and trabeculoplasty, patients with angle closure glaucoma, patients having pre-existing corneal or retinal pathologies, patients having neuro-ophthalmological diseases, and patients who were already on anti-glaucoma medications. So coming to methodology, the study area was Eye Care Eye Hospital and Postgraduate Institute, Noida, and study population were all the patients with normal tension glaucoma. Study design was hospital-based retrospective study, and the sample size were 45 eyes. So 45 eyes having normal tension glaucoma was studied, and data on intraocular pressure, central cornea thickness, Humphrey's visual field, and OCT RNFL before and after the diagnosis of normal tension glaucoma were noted in patients before starting anti-glaucoma medications and followed up for 5 years after starting 1 to 2 anti-glaucoma medications. So the results: the mean intraocular pressure was between 15.71 millimeters of mercury before starting the medications and 12.86 to 13.44 millimeters of mercury after starting 1 to 2 anti-glaucoma medications. 7 eyes had normal visual field on HVF at presentation, out of which 5 eyes showed progression, and 7 eyes having normal OCT RNFL at presentation showed progression after 1 year. 6 eyes had mean central corneal thickness of 480 microns, and rest all had values between 520 to 570 microns. Overall, out of 45 eyes, 16 showed progression and 29 eyes remained stable up to 5 years. Out of 16 eyes that showed progression, 4 had history of migraine and 10 patients were on antihypertensive medications at night. So, conclusion: normal tension glaucoma is within the spectrum of open angle glaucoma, having intraocular pressure consistently below 21 millimeters of mercury. Controlling intraocular pressure as low as possible is the key to manage the normal tension glaucoma patients, along with control of systemic factors like migraine and vascular causes like hypertension. Antihypertensive treatment at night causes decreased optic nerve perfusion, which leads to progression of glaucoma. Normal tension glaucoma is often underdiagnosed, but according to this study, it has 35.55% chances of progression even after starting the anti-glaucoma medications. Therefore, normal tension glaucoma patients should be evaluated for relevant systemic factors and regularly followed up to rule out the progression and stop further damage to the optic nerve. Thank you.
Thank you, Usha. So, most of your patients were on one or two medications. You said
Yes,
none of the
ma'am.
patients required more than two medications.
No, ma'am. Because intraocular pressure was maintained till 13 millimeters of mercury, ma'am. Maximum till 2, I kept the patients.
Okay.
Yes,
So,
ma'am.
none of
For
the patients
study.
had more than 13.
No, no, ma'am. None.
Okay. So may I request the next speaker to be there on the
that side.
dais till that time? So,
Dr. Ankita, please,
Ankit.
on that side you can go. So how you explain the higher percentage of progression in your case? You said it will be 35%.
35.55%, yes, sir.
So 35.5% when the patient is on treatment for 2 drugs and even the
Yes,
IOP
sir.
you said target was 13.
So in normal tension glaucoma, in many studies, it has been shown that the vascular factors are also contributing to the progression of the disease. So despite maintaining the intraocular pressure around 12 to 13 millimeters of mercury, patients, especially patients on antihypertensive treatments, and many of the patients are having migraine also, those patients were progressing. So it basically...
did you do diurnal? Because 13 is the daytime pressure. Diurnal variation.
Diurnal
did you
variation at the beginning of the diagnosis, ma'am, diurnal variation was done, but since I've done a
24 hours.
retrospective,
24
It's
hours
office hour or
diurnal?
24 hours?
ma'am, day hours during
So
the
you are not
time.
sure about the morning pressures or night pressures?
Yes, ma'am.
And,
Yes, ma'am.
and did you do some 24-hour ambulatory BP monitoring? You said if there are vascular factors, because it's pretty
Ye-
high,
yes,
very high
sir.
incidence of progression,
Yes, sir.
which would lead you to a very high risk ratio, you know.
Yes, sir.
Okay, thank you.
Thank you.
Okay, thank you.
So the next speaker, where is she?
Dr. Anita,
Yeah.
if you want this side. And next is
Okay.
Dr. Pratibha. Dr.
Good morning,
Pratibha
all.
is here?
Yes, sir.
Yeah, please start.
Good morning, all. My paper presentation is on a cross-sectional study of anterior chamber angle parameters and biometric parameters in patients with shallow anterior chamber and their siblings at the tertiary care center in Eastern India. Glaucoma, as we know, is a chronic progressive optic neuropathy leading to irreversible blindness and mainly is of two types, open angle and close angle. However, close angle glaucoma, it leads to 2.5 times more blindness compared to primary open angle glaucoma. And a positive history of glaucoma is an important risk factor which predisposes sibling to shallow angle to angle closure 8.8 times compared to the normal general population. The slide stuck. So these are the abbreviations used. My primary research objective was to evaluate the difference between the anterior chamber angle opening distance at 750 microns from the scleral spur in the two groups, which were probands and siblings. And the secondary research objective was to evaluate the different angle and biometric parameters. So my study design was cross-sectional and observational, which was done at Ophthalmology OPD and recruited 20 to 60-year-old males and females. And outcome variables were measured. As they were continuous variables, it was analyzed using independent t-test. The patients were recruited who had a shallow anterior chamber of VH grading 012. Consent was taken and they were counseled to bring the sibling along on the next visit, and they underwent AIOS with Heidelberg spectalis and biometry after consents. And the outcome variables were measured. So here is the slide of the AIOS which is showing the angle parameters, of which in my study the concern was of anterior chamber width, which was the distance between the two scleral spurs. Lens fold, which is the horizontal distance which is the perpendicular drawn on the ACW to the anterior surface of the lens. AOD 750, which is the opening distance at 750, we already discussed, and TISA, which is trabecular iris space area at 750 microns. Here is an image of my patient in which I am showing the 4 parameters. It was measured at the nasal and temporal angles. And this is a magnified view which is showing the AOD, ACA, and TISA. TISA is the orange enclosed part which is trapezoid in shape. And here is the biometric parameters which was done using IOL Master 700. And the parameters which were studied were axial length, TK1, TK2, anterior chamber depth and lens thickness. So in the results, the major population of study was, the participants were 84% females, and there was not significant, statistically significant difference in the age of the participants, and all the variables were normally distributed, and as I said, t-test was used. So here is the nasal AOD 750 and temporal AOD 750. It showed significant statistical difference in both the patient and the siblings group. There were other 9 variables which showed statistically significant difference in both the probands and the siblings. There was again a subgroup analysis done with the patient and sibling pairs. They were divided into 2 pairs, concordant and discordant pairs. Concordant pairs were the siblings with the probands and the siblings both having shallow anterior chamber, while discordant pairs were the siblings who had an open angle while the proband had a shallow anterior chamber. Of which 7 variables showed the difference between the, there was statistical significant difference in the discordant pair, but there was not statistically significant difference in the concordant pairs. So my conclusion was that the 7 variables which I have studied, the nasal parameters of AOD 750, TISA 750, ACA 750, the lens volt, anterior chamber depth, axial length and lens thickness, they can be used as screening tools using AIOS2025-Hyde to screen the concordant siblings who are predisposed to shallow anterior chamber. And however, the corneal parameters which were analyzed were not statistically significant in both the groups and not even in subgroup analysis. Thank you.
Thank you. So, which OCT did you use? Which AIOS-OCT?
Ma'am, Heidelberg Spectralis ACA module.
Okay, so what is your like the family member should be screened on AIOS-OCT to rule out glaucoma? Is it feasible?
Ma'am, we can use of which the parameters which were to be concerned when we are doing AIOS-OCT in the siblings were the nasal values, lens volt, anterior chamber depth, and lens thickness.
So you can use it?
Yes, ma'am, we can use it. And
how practically feasible it is? I'm asking that. My question is for screening purposes.
Ma'am, actually this thesis was done in the government setup, so.
Just one question.
No,
You
it's
said
not
that
like
there was a
this.
significant difference in the concordant, whereas in discordance there was no significant difference, right?
In few parameters, yes, sir.
So, how did you define the concordant and discordant? Just from the presence or absence of open angle?
No, sir. Concordant pairs were the patient already had shallow anterior chamber, but the sibling also have shallow anterior chamber were concordant pairs.
So that means, if from your study, all we need to see is whether the siblings have a shallow anterior chamber or not. And
Yes,
they will
sir.
be statistically significant. That's what your study says.
Yes, sir.
Isn't that correct?
Yes, sir. To find out that, how many siblings also had shallow anterior chamber, and also what the parameters which we can use to differentiate the siblings who have shallow anterior and open
Your
angles.
recommendation will be just look for siblings with similar kind of anterior chamber. Is that right, or am I getting it wrong? What is your recommendation?
Sir, all the parameters which were matching to a shallow anterior chamber, clinically also those siblings had VH1-2 grading. So definitely, if the sibling is having shallow anterior chamber, we should go for an AIOS-OCT. And if the sibling is having open
Can also do
chamber,
gonioscopy, like that is what I was asking. Is it feasible to do AIOS-OCT for screening of all? Can't you do gonioscopy?
no, ma'am. Then it will be for shallow anterior chamber.
That's what
Yeah.
sir is saying. First,
Ma'am,
you
I
do
got
the
your question now.
1RX.
Yes.
If it will be 2 or less, then you can go for these anterior segment OCT parameters for the siblings. Unless you identify first
Yes, sir.
with either gonio or with the 1RX method,
Yes,
then
sir.
doing AIOS-OCT for all the people is not
No, sir,
practically
we
and
won't do
feasibly
it for all the
possible.
patients.
Very
Yes,
good.
sir.
Go ahead.
Okay.
Thank you, sir.
Next speaker?
Next
Is
is
she
Dr.
there?
Pratibha Kataria. She is absent.
Acha, okay.
Okay.
Who is the
Apurva.
next?
Dr. Apurva, please.
Pratibha is absent. Okay.
Next to Apurva, Dr. Mayuri. You are here. You can come in this side if it will be there. Everyone stick to your time limit
She is
because
Apurva.
Mars.
Yeah. not displaying the time.
नहीं display blue
अच्छा है?
blue display
अच्छा ऊपर है not
Yeah.
नीचे.
Dr. Apurva, please start.
Good afternoon. I will presenting a glaucoma something as a case study on a visual field mystery. Glaucoma is a chronic progressive optic neuropathy. The main neurological condition as masculine glaucoma. The case series of patient diagnosed with glaucoma undergoing treatment. Case 1, 44-year-old teacher. Diagnosed as nervous tension glaucoma elsewhere. Optic nerve had this asymmetrical 3D ratio. Right eye 0.9, left eye 0.8 with shallow cupping. Perimetry of both eyes bitemporal hemianoptic visual field defect respecting the vertical meridian. MRI branch 2 into 1 into 1 10 mass lesion with suggested with adenoma or meningioma. Case to 50-year-old female, anti-glaucoma medication, both eye duration of 0.9 with shallow cupping with optic displacer. Perimetry showed right eye visual field defect, left eye loss of visual field. MRI shows left penile meningioma encasing the left intercalary artery with optic chiasma with cerebral atrophy. After neurosurgical visual field in the right eye was stable. Case C, 70-year-old male, optic nerve 3D ratio, right eye 0.7, left eye 0.9 shallow cupping. Both eye perimetry showed left superior contentopia with left eye inferior glaucoma. MRI branch showed oral infarct in right parietal and temporal lobe with glasses. Case for 44 female, no systemic complaint, conioscopy showed narrow ocular angle. Both eye perimetry showed right eye superior contentopia. MRI angiography showed left cerebral, temporal and occipital infarct with 2D echo revealing rheumatic heart disease with severe mitral stenosis. How to look for RP means criteria for subtle hemianoptic defect. Compare the decibel value on either side of the vertical meridian. The corresponding fade on the next house adjacent to the first could also show different. Difference of blue decibel value is significant and suggests early hemianoptic defect. Okay, so case series of 4 patients having neurological visual field defect misdiagnosed as glaucoma. The first 2 patients had neurological visual field neurosurgical life-threatening condition which required neurosurgical intervention. The third patient had a cardiovascular old infarct along with glaucoma neuropathy, and the fourth patient had a cardiovascular condition requiring anti-embolic treatment along with PSA. So neurological imaging should be done if visual field and optic findings are typical of glaucoma. Conclusion, proper history of underlying condition, if any, a detailed evaluation necessary to confirm diagnosis. Visual field and optic OCT help differentiate the neurological lesions from glaucoma. Proper management for neurological condition can be life-saving and light-saving. We may avoid unnecessary treatment for glaucoma. These are reference. Thank you.
Thank you. So how do you differentiate, just a clinical question, between the optic nerves of neurological versus glaucoma patients? You said pallor. How do you differentiate? How did you differentiate in your study between the glaucomatous optic neuropathy and neurological?
Glaucoma they have there is pallor more, cupping more than pallor in the optic.
And what about the fields? Fields? What is the differences between the fields?
And the visual fields.
Visual fields between neurological and glaucomatous. You have already presented, I am just trying to ask again. What are the differences?
Okay.
Oh, anyway.
Next.
She's getting
Dr. Mayuri,
Okay,
please.
thank you.
Meanwhile, Dr. Satish is here. Please come to this.
Hello. Is the slide visible? Audio visual. Yes. May I start, sir? Yes. Good afternoon, everybody. This is one of the presentation that I wanted to show that in my experience, when I go to a multi-specialty hospital, I come across patients who present with neuro-ophthalmology and they have other problems like gynecology also. So this is one of the cases. The audiovisual team, can they just come and help me? It is not accepting this. Yes. So this is one of the cases that I've come across in my practice in last year, and she was a gravida 2 para 1 36-year-old female patient who had complained of double vision and blurring for 2 days. Her only history which was evident in the present pregnancy was a hypertensive history of 150 by 90 millimeter of mercury. Apart from this, she had no other practical symptoms. She came to the ophthalmic OPD with a presentation of, as said, 150-90 millimeter of mercury, and all the other parameters of the eye was normal, except that her movement of the left eye was limited to the left side. And there was no other offensive findings. There was no papilledema in the fundus examination, but there were slight grade 1 hypertensive changes. She didn't have any history of head injury, syncope, or seizures during the pregnancy. So during examination, we could see that the lateral rectus of the left side was absolutely paralyzed, and she was having blurring vision. So the neurologist in the hospital had already ordered for the MRIs. They had already been done. He could not find out any abnormality anatomically in the patient, and they had already also ordered for the contrast enhancement. That was also normal in this case. So what next? To discuss, absolute LR palsy in pregnancy is a rare condition in theory also so far. They could present with seizures, inflammation, intracranial pressure changes, and it could be a very false localizing sign to the gynecologist as well. But we have to take out the MRIs and pictures and the radiological evidences to rule out the space-occupying lesions like the meningioma or the chordoma that might be there. And we have to keep in mind that there was a sudden rise in BP of the patients. So the differential diagnosis of this patient would be definitely a pituitary adenoma because of hormonal changes, or baby because of diabetes, hypertension, or any other tumors. Why lateral rectus is commonly involved? Any bleeding, infarction, or any constriction or vasospasm or thrombosis will actually very easily affect the lateral rectus because it has a longest course in the orbit, and it takes a little bit long duration for recovery. So in this patient, the patient was furious, the attendants were furious, but all I had to tell them was to please wait and watch, because since all the parameters were normal, we could take a chance of taking a medical management. All the blood investigations were within time. So what did I did? Basically nothing. So you say it best when you say nothing at all sometimes, and we have to explain to the patient that it will take its own natural course. The Maxwell regimen was taken by the gynecologist. She was treated. The patient did not even agree to patching for diplopia because she used to feel nervous. So after a few months, thankfully, she came to normal after 8 months. And just to show that this was a rare case, because even in literature, if we find, there are very few cases that have been reported, only 9 cases so far from 1968 to 2015, and all these cases have resolved within a period of 1 to 3 months to 6 months. So sometimes it is actually that we don't need to intervene and we say nothing at all. Thank you.
Thank you. So it was just one case.
This one case that I had come across, ma'am, and literature, it has been reported 9 cases so far. So I reported this case. It is absolutely unusual, and it is basically the management part becomes difficult, ma'am, because the patient's attendants and all are very furious. So we waited, and the gynecologist managed the, basically in the line of PIH. So once the delivery was done, after the cesarean section, it took, I kept the patient for follow-up for 8 months, and now she's absolutely fine.
Spontaneous resolution.
Yes, yes, yes.
Okay, thank you.
Thank you, ma'am.
Dr. Mayuri is here.
Yeah, she was there, Mayuri. She is presented.
No. Yours, Mayuri Bora. And Mayuri Pathak is next one. That's why I'm
Mayuri
asking.
Pathak, yes.
Anyone Mayuri Pathak here? No. So next presenter will be Dr. Sagrika. Dr. Sagrika, please come to the podium.
You can start.
Meanwhile, Dr. Satish, please start.
Good afternoon, everyone. Today I am going to present a rare ocular presentation of bilateral megalocornea and high intraocular pressure in a Treacher-Collins syndrome. Overview of Treacher-Collins syndrome. It is a rare autosomal dominant condition primarily affecting the first brachial arch structure, that is eyes, ears, and facial bones. It affects about 1 in 50,000 live births. It primarily presents with craniofacial features, and ocular features include low-lid coloboma, antimongoloid slant of palpebral fissure, canthal dystopia, ectropion, dermoids, and high astigmatism. Coming to my case, it's a 6-month-old baby diagnosed with Treacher-Collins syndrome, referred by a pediatrician for ophthalmology assessment to a tertiary eye care center. The mother was concerned about notched eyelids and downward slanting of both eyes of the baby since birth. Coming to the birth history, it was a full-term baby delivered by elective LSCS to a non-consanguineous marriage. And the pedigree chart of the 3 generation confirmed the sporadic nature, and systemic examination were within the normal limits except for the features of Treacher-Collins syndrome, that is lid coloboma, downward slanting of palpebral fissure, micrognathia. And the baby was able to fix and follow the light, and the intraocular pressure in the right eye it was 22 mm of mercury, and in the left eye it was 26 mm of mercury, measured by using a rebound tonometer. Coming to the anterior segment examination, The right eye lower lid showed a defect of 2 cross 1 millimeter near the lateral canthus with loss of eyelashes, with megalocornea and prominent globe and prominent nose with antimongoloid slant. The similar findings were noticed in the left eye along with lag of thalamus. In the first picture, you can see the hypoplasia of the zygomatic bone, hypertelorism, antimongoloid slant, and micrognathia. In the second and third picture, you can clearly see the lower lid coloboma with loss of eyelashes. There is no evidence of HAP striae or ophthalmus, and we have started the patient on dorzolamide eye drops in both the eyes. And we have planned examination and anesthesia after a week, and we confirmed the megalocornea with a corneal diameter of 12.5 cross 12 millimeter in both the eyes, with a deep anterior chamber depth of 3.41 millimeter in the left eye. Apart from that, the intraocular pressure, axial length, fundus, optic nerve head, and foveal reflex were normal. Coming to the systemic and genetic investigation, there was a small atrial septal defect and mild pelvic-calcial system separation is noted in the left kidney. And the cytogenetics confirmed the male karyotype, and genetic analysis showed heterozygous mutation in the TCOF1 gene, suggestive of Treacher-Collins syndrome. And my diagnosis is Treacher-Collins syndrome with bilateral coloboma of the lower eyelid with megalocornea. And we have started on dorzolamide 2% eye drops twice a day in both eyes in order to prevent the infantile glaucoma, and conservatively treated to prevent the exposure keratopathy. Coming to the discussion, more than 60% of Treacher-Collins syndrome were sporadic, and according to Franchetti and Klein classification, it is further subdivided into 5 types, that is complete, incomplete, abortive, unilateral, and typical. I will categorize my patient under typical form. So the take-home message, megalocornea is not commonly associated with Treacher-Collins syndrome. To the best of my knowledge, only one case was reported so far. And megalocornea with high intraocular pressure is not a definitive sign of congenital glaucoma unless ophthalmos and other signs are present. Careful evaluation is needed to avoid misdiagnosis and unnecessary aggressive intervention. Follow-up is important to monitor for glaucoma development in future. And a multidisciplinary approach involving ophthalmologist, pediatrician, radiologist is essential for optimal care and early intervention, especially for parental counseling. This case emphasizes the importance of refining diagnostic criteria and treatment strategies for syndromes with atypical presentation. These are all my references. Thank you.
Okay, thank you. So it's a very rare condition.
Rare.
One thing is that you can go for the IO case publication for this.
Yes.
You have all the documentation, plan it and write it in a proper way and submit to the IO case reports.
Sure, sir.
Wishing you good luck for that.
Thank you, sir.
Maleshwari, yeah, please come on the dais. Meanwhile, Dr. Sagarkar, please.
Okay. Blistering surprise, epithelial bulle formation post trabeculectomy, bleb massage. It is not. So trabeculectomy stands as gold standard and most frequently performed glaucoma surgery, and post-operative bleb massage is a common practice aimed at promoting aqueous flow through the newly created pathway. However, there are potential complications of bleb massage like hypotony, shallow anterior chamber, iridocorneal touch, hyphema, even suprachoroidal hemorrhage and choroidal effusion are reported. Here I will present a novel complication following trabeculectomy, that is corneal bulle formation post-trabeculectomy bleb massage. So patient is a 50-year-old female who presented with pain in her left eye from last 1 month, and on examination there was angle closure and markedly elevated intraocular pressure, 60 mm of mercury. There was posterior synechia and complicated cataract. So first medical management was done to decrease intraocular pressure, and surgical intervention performed. Patient underwent combined phacoemulsification and trabeculectomy under mannitol cover. On post-operative period, intraocular pressure remained high, 38 mm of mercury, with a flat congested bleb along with fibrin reaction in the pupillary area. So bleb massage was done to administer enhanced outflow through bleb, and decrease in intraocular pressure from 38 mm of mercury to 22 mm of mercury noted post massage, but there were the bleb was flat and there were multiple well-defined corneal bulle emerged near the superior limbal area near the bleb. So further massage was withheld and releasable sutures were removed, leading to bleb formation, and there was subsequent decline of IOP in to 14 mm of mercury. Another patient was a 60-year-old female patient who presented with uncontrolled IOP of 50 mm of mercury. There was history of acute left eye congestion 5 months prior, which resolved after use of unspecified medications. On examinations, there were pigmented KPs, posterior synechiae, complicated cataract. Patient was diagnosed as secondary angle closure glaucoma and underwent combined trabeculectomy and phacoemulsification under steroid cover. Initially, IOP was controlled 8 mm of mercury, although there was flat blab. And on post-op day 7, IOP surged to 40 mm of mercury. We removed the releasable suture, but there was no formation of bleb. And the bleb massage was given. And again, in this patient also, multiple bullae emerged near superior limbal area, proximal to the bleb. So further massage was withheld, and definitive management was planned with the medical management and bleb revision after resolution of fibrin and congestion. So in both of our cases, combined cataract surgery and trabeculectomy was performed in patients with complicated cataract, and intense fibrin reaction was noted in post-operative period. So our hypothesis suggests that during scleral flap creation, the dissection of the scleral flap that extended more anteriorly in the corneal plane beyond the sclerostomy. So sclerostomy was patent, but when we gave the bleb massage, so aqueous traverses through the sclerostomy, but because of the tight scleral flap sutures, it could not go in the subconjunctival space, but it found its way in the corneal plane, and there was reverse migration in between the corneal layers and formation of intracorneal cleft and bullae formation. Similar to our case, in a patient with post-glaucoma drainage device surgery, acute intracorneal cleft formation occurred after massage. And in another patient, when ocular massage, post-trabeculectomy, ocular massage was done by patient at home, and patient presented with acute ocular pain and redness, and there was corneal eye drop secondary to the ocular massage. So these cases emphasize that reduced intraocular pressure post-massage may not solely indicate bleb formation, and there may be they may potentially lead to development of intracorneal cleft. The tightly sealed scleral flap can obstruct the aqueous flow towards subconjunctival space and may lead to reverse migration between corneal layers, causing bullae formation. So timely identification of this complication is crucial, as further massage may exacerbate bullae formation and may lead to corneal eye drops. Thank you.
Thank you, Dr. Sagarika. One question.
Yes, sir.
In your first case, you did trap with releasable sutures.
Sorry, sir?
Your first case was trap with releasable suture.
Yes, sir.
So, on what day you did this bleb massage? Means
Sir,
if there is
initially-
any bulla, then you can remove the releasable sutures. It already released your
Yes, sir. We could
tightness
have
or
done
whatever
that.
you
I did the
hypothesized.
massage first, and so there was bullae formation, and then I released the releasable suture. After that, IOP decreased to 14 mm of mercury.
Later, after bullae formation. So what message will you like to
Like
give?
If there is a decrease in intraocular pressure, we should see carefully if bleb is forming or not. There may be corneal bullae formation, and if there is like fluid in between the corneal layers, so we should stop the massage.
Then how will you do the massage? I think, is there something to do with the massage you do, like in which direction, from the lower
But it
lid
doesn't
or
happen
from
in
the upper
every
lid
patient,
or
ma'am.
in between the sutures? Is there any particular way which can prevent this finding of doing the massage? Or
It may be related to the surgery, like.
But it is not a very common.
Yes,
even if
ma'am.
the scleral
But it
sutures
doesn't
are
happen
tight,
always.
You massage it, it doesn't go the reverse way in most of the cases. I think it also depends where you are massaging, whether through the lower lid or from the upper lid.
No, from the
And-
lower lid I do it.
Okay. So
I ask the patient to look in the down gaze from the lower lid, and under the direct observation I do the massage,
so when
and
you're
I can
doing
see
it
that.
from lower lid, so ideally it should not come
Come outside.
out. But it should go out. Not,
Yeah,
it should
and
not go-
yeah, I do massage in my patients, and also,
Okay.
but I have seen in just 2 patients I have seen
So the
this
sutures
complication.
you mean are very, very tight.
Yeah.
I think you should put, less tight sutures. Sutures should be slightly.
But in both patients, there were fibrin reaction and complicated cataract. Like in one patient, it was post-uveitic attack, and in another patient, acute angle closure attack in 1 month back, and then she also had complicated cataract. In both patients, there was and fibrin reaction was also noted in post-op
Basically,
period.
these fibrin reaction leads to blebitis.
Yeah.
There will be a inflammation which
In the
carry
bleb.
forward inside the bleb and other things there. But it's okay. And whenever you will find out these blebs or anything and you have did a relegible suture, then remove the suture first,
Yeah.
so that it gives passage for the drainage if it is exactly because of the tightness of the posterior flap or the ostium flap.
In fact,
Okay.
1960s, there was an article by Treviso which talked about post-trabeclectomy, when there is a lot of fibrin, the scleral flaps tend to adhere. So there is something known as a Treviso's maneuver, where you do a direct massage on the bleb, so as to release the fibrin adhesions
Fibrin
between the two. So in such cases, when you have done a cataract along with the glaucoma procedure, and we have a lot of fibrinous things, a direct massage before that you can do a traversos to make sure that the drain is happening, the scleral bleb, and then you can go the traversos maneuver followed by the this thing.
Dr. Nupur is here.
Thank you.
Dr. Nupur, she is not here. Next is Dr. Narendra. Please come to this podium, sir. Meanwhile, you start. Dr. Maleshwari.
Yes, sir. Good afternoon, sir. Good afternoon, all of you.
Nupur is absent.
It's not moving. So, hypertensive maculopathy is one of the complication of trabeculectomy, and timely management can avoid the vision-threatening complications. And I am presenting here 2 cases which were managed differently. And finally, the patients came with good vision and the better control of intraocular pressure. This 26-year-old male patient, who is a physical trainer, came with angle decision glaucoma, and he underwent trabeculectomy for the uncontrolled pressures. And after trabeculectomy, 2 weeks after that, the pressure was again high. So my colleague did laser suture lysis. After that, the pressure suddenly came down to 0, and there was a decreased vision, and vision dropped down from 618 to 4/60. Cornea was clear, AC was well formed, but there is a disc edema, so which was shown here, and the macular folds also there, and the macular thickness was increased 377 microns. So when I saw through the conjunctiva, there was a raised flap where the apical suture was raised. So I went inside, and then I tried to suture the scleral flap with 10 sutures, and then I want to reinforce the bleb area with the scleral patch graft. 2 weeks after that, the bleb is well formed, and the pressure raised to 12 millimeters of mercury, vision improved to 612, but there was an exposure of the scleral patch graft. So again, I did mobilization of the conjunctiva and AMG graft. So this was the 2 weeks picture where the patch was very well covered, but this is the fundus picture where there is an increased disc edema on the macular folds. Again, the vision dropped down to CF 1 meter. So I searched for the literature, and then I thought of doing autologous blood injection, where 0.5 cc of autologous blood is taken from the cubital vein and then injected into the bleb area, which was seeped into AC also. 3 weeks after that, this is the pre-injection picture, and these are the serial OCTs where you can see the improvement. And this is the final picture where the disc margins were clear and the macular edema reduced, and the patient got vision of 6/9 with the control pressure 22 without any anti-glaucoma medication. And here is the second patient. This patient, actually Jonine open angle glaucoma patient, he underwent trabeculectomy. I only did the surgery, but he lost follow-up for 15 days and stopped steroids after 5 days of surgery. And the vision was 5/60. He was denying any history of trauma, but pressure was 6 millimeters of mercury. I was soft, but AC was well formed. So I thought of managing medically with the oral and topical steroids, but after 2 weeks also the ILM folds were remaining. So this was the picture where I can see the scleral flap tightly opposed to the sclera with the apical suture. So I thought of, okay, I can manage it with injection because AC is well formed. So initially I first thought of doing autologous injection, but didn't work in this patient. So I went inside, and again I did the scleral flap suturing and reinforced with the scleral patch graft. And finally, this is the outcome. So these are the serial OCTs from the April 24 to February 25, where there is a gross improvement in the macular area. And finally, the patient got the vision of 6/9 and the pressures around 12 millimeters of mercury. And the ocular integrity can be achieved in similar cases, but with the different modalities. And a timely shift in the management options can salvage the vision of the patients. Thank you. Jai Jai Shankar, Har Har Shankar. Thank you, sir.
Your first case, your OCT showed a lot of ORCs, that is in the outer retinal corrugations. This
Sir.
is clearly an indication of RPE, disease. I mean, so we can expect that the macular edema will not resolve by itself for a long time. So, in your first case. In the second case, yes, please.
So actually we took the opinion of retina also, sir. But they were telling because the pressure is low, if the macular folds on the disc edema will be there in hypertensive maculopathy, but it is very rare condition. Once the pressure is improved, then it may improve the condition. Because in the first, after suture lysis, it came to me, and then I did resuturing. Pressure increased to 12 millimeters of mercury, vision improved to 612. Even before, just after the surgery, it was 618 because of the cycloplegics, but it got improved to 612. But again, because the scleral patch graft is exposed, I just want to cover it because of the fear of blebitis. So after 2 weeks, again the patient came with the severe disc edema and the macular folds, and the vision came down to CF 1 meter. So young patient, 26-year-old patient, male patient, physical trainer, I was worried. So I don't want to take him to war again. So I just thought of search the literature and just thought of giving a try with the injection, autologous blood injection. Exactly the procedure is the simple one only. So it went inside and the fibroblast will cause fibrosis. Where it went, how it caused fibrosis, I don't know exactly. But finally the outcome is the patient vision, he got back 6.9 and the pressure is 22 because the discharges are not much and the vision is regained. I was happy. So for the second patient, I thought of, because I did the surgery, I know that scleral flap was well opposed. So I thought of giving a try with the injection first, but it didn't work in that patient. So I went inside and just sutured the flap again and reinforced with the patch graft. And after that, he developed a cataract and removed the cataract. And now last month, I did 1 month follow-up of cataract surgery. His vision is 6.9 and there is a lot of change in the macular area. And so I thought these two cases are different.
Yeah,
And
I think you're right that sometimes you have to do multiple procedures. One procedure may not be effective for every patient. Okay,
Yes, ma'am.
thank you.
Dr. Sonam Burma, please come to the desk. Meanwhile, Dr. Naren, please start your presentation.
Here.
Dr. Naren, presentation. हाँ. Dr. Sukanya is here.
No, कौन सा है इसका नाम नहीं आ रहा.
Dr. Sukanya Padi.
हाँ, किसी में
And Dr. Kajal.
ये इसके ये सही वाला.
Dr. Kajal is here in the hall.
नहीं ये नहीं. इसके ऊपर वाला. हाँ ये बस ये. Good afternoon all. I am presenting a case of rare case of suspected congenital glaucoma with shallow anterior chamber. The case history: a 2-month-old male referred by general ophthalmologist for congenital glaucoma evaluation. According to informants, eye appear large with whiteness over cornea, right eye more than left eye since birth. The birth history of complicated vaginal delivery after birth. Patient was admitted for asphyxia in NICU for the 10 days. On torchlight examinations, both eye appear ophthalmic, right eye more than left eye, and right eye cornea was hazy. IOP by tonopen 31 mm Hg and left eye 25 mm Hg, with 4 AGM, ripasudil plus timolol and brimonidine plus brinzolamide eye drop. We switched AGM and started ripasudil plus timolol with dorzolamide eye drop BD, because the brimonidine is contraindicated in up to the 4 years age. That is OPD pictures of patients. Right eye, that is left eye. B scans within normal limits. There is no any significant findings noted. Then we plan for the EOA that patients. On EOA examinations, IOP in right eye is 2 mm Hg by tonopene and left eye is 5 mm Hg by tonopene, maybe due to the post anesthesia. Corneal diameter is horizontal 13 mm, both horizontal and vertical 13 mm in right eye, left eye horizontal 10 mm and vertical 9 mm. Axial length right eye 23.37 mm and left eye 18.12 mm. Retinoscopy right eye red glow absence and left eye was -1 diopter spherical and -2.25 cylinders 20-degree noted. Keratometry right eye is error and left eye is with the rule astigmatism noted. On anterior segment examinations, right eye cornea was hazy, shallow, flat, AC with VH0, appear iridocorneal touch, sacclusopupillae 360-degree posterior saniki presence. In the left eye, cornea was clear, pupil irregular after dilatation and posterior saniki was present. On fundus examinations, no view in right eye, left eye disc pallors. It's appear like 0.85 to 0.9 CDRs, macula and retina is on. On the basis of EU examination on SAM settings, we have the done right eye trap plus trap with MMC 0.1 milligram per ml subconjunctival injections and papilloplasty with first we attempt the that normals manually the membranes, but it's not done by the manually. Then we plans for papilloplasty with membranotomy by the anteroctectomy cutter. Later on, we also done the TOS analysis, and we found that the cytomegalovirus IgG, IgM positive in both patient and mothers. On post-op treatments, tobramycin eye drops given 4 times a day for the 1 month, and Predmet eye drops planned for 4, 3, 2, 1 in taper dose in 2 weeks. Atropine eye drops continue for the next follow-up, and Aclopol DX ointments for HS for 2 weeks. On follow-ups, day 1, we saw that lead edema noted, raised details are not clear. Day 3, cornea was hazy, SK edema presents. Anterior chambers appears well forms. The post-op 15 days, both eyes 7 mmHg by tonopanes IOP noted. And 1.5 months, right eye IOP was 13 mmHg and left eye 16 mmHg. That is 1.5 months post-op image. It's cornea was hazy and little bit corneal opacity also noted on 1.5 months age. Thank you so much.
So what was the diagnosis?
Actually, it's still, I suspect some secondary causes, but I have written the congenital glaucoma suspect with shallow anterior chambers.
But it is not congenital glaucoma.
Yeah, ma'am, it's appear like some secondary causes, but on the headings I written like that congenital glaucoma suspect.
Cytomegalovirus positive. So what could be the probable diagnosis?
I couldn't get what.
So you had that
Yeah, ma'am, I also discussed with, but later on, no, I think we can't give any. I also refer that patient for pediatricians, but pediatrician say that we can't do anything because already the deliveries happen and patient is quite, there is no any symptomatic.
How much was the corneal diameter?
13 mm in both eye. Right eye is 13 mm.
Okay.
13.
And
yeah,
age,
right.
Age of the patient?
2 months, ma'am.
Ajay, 13.
Yes.
But it could be secondary. Yes, secondary.
I still searching at what could be secondary. Maybe post-op, like a post-vaginal delivery maybe can happen. Maybe some tear or maybe some that time of infections occur and maybe lead to the uveitis and that goes into the secondary glaucoma. But still, what could be the diagnosis? I am not sure. Yeah. Excellent. All are the positive finding in the right eye, left eye, but only the positive finding was the disc pallor. It's appear like 0.85 to 0.9 cups. Thank you.
Usually in viral infection, you will see the changes of the inflammatory, means disc pallor, other thing will be there, but the change in axial length is slightly unexplainable why there is a change in the axial length at that time. It's okay.
Thank you, sir.
Dr. Mayuri Pathak, these two. Dr. Sukanya, Dr. Kajal. Okay, so no one is there. Last presentation by Dr. Sonam Barma of this session. Dr. Sonam, please.
Good afternoon, everyone.
My topic of presentation is assessment of anterior segment parameters in pseudoexfoliation spectrum. Pseudoexfoliation syndrome is an age-related condition characterized by gradual deposition of an abnormal fibrillar extracellular material in the eye and other organs of the body. It affects about 3 to 6% of population. Males are more affected than females, especially in Indian population. Multifactorial causation has been causing the pseudoexfoliation syndrome with the genetic, UV radiation, autoimmunity, low ambient temperature, slow virus infection, and trauma as a causative agent. Primary effects on the anterior segments of the eye are poor pupillary dilation, pupillary rough defects, breach of blood-retinal barrier, open angle glaucoma, cataract, zonular weakness, subluxation of the lens, and anterior displacement of the lens iris diaphragm. The aim of my study was to compare anterior segment parameters in patients with pseudoexfoliation glaucoma, patients with pseudoexfoliation syndrome, and normal subjects using pentacam imaging, anterior segment optical coherence tomography, and specular microscopy. It was a single-center study, cross-sectional in nature, and I had taken 20 patients in each group. On pentacam Scheimpflug imaging, we can see the anterior chamber parameters of anterior chamber depth, anterior chamber angle, anterior chamber volume, all varied between all the three groups, but the differences between the pseudoexfoliation syndrome and pseudoexfoliation glaucoma group were not that significant, but comparing to the control group, the anterior chamber parameters had significant difference. And all these differences were related to the gradual thickening of the lens. That is, the lens thickness has gradually increased from control to pseudoexfoliation group. Anterior segment optical coherence tomography examination. In this, I had compared the angle parameters of angle opening distances and trabecular iris surface area. These parameters were significantly lower in pseudoexfoliation syndrome and pseudoexfoliation glaucoma group as compared to the controls. And on specular microscopy too, on seeing the endothelial cell density, there was a decrease in pseudoexfoliation syndrome, but the coefficient of variation and hexagonality were altered insignificantly between the groups. Our study indicated that there is a progressive decrease in anterior segment biometric characteristics from normal control subjects to pseudoexfoliation syndrome and the pseudoexfoliation glaucoma group. A variety of mechanisms can be causative factors for these findings, such as thick iris, formation of posterior synechiae, zonular weakness. Zonular weakness can cause anterior shift of the lens iris diaphragm, which can be said to cause the variation in these anterior chamber parameters. So there is a progressive decrease in the angle parameters from control subjects to pseudoexfoliation syndrome group to the pseudoexfoliation glaucoma group. Additional studies were needed for better determining the mechanism and significance of these parameters. The limitations were small sample size and the cross-sectional nature. We couldn't follow up the patient, and it was a single-center study. Thank you.
Okay, so is it like we already know that pseudo exfoliation can cause shallowing of anterior chamber? So what is so new about this study?
I am comparing it to, it causes primary open angle glaucoma. I wanted to assess if it is the additional factor for causing glaucoma. So here I'm comparing pseudoexfoliation syndrome group and pseudoexfoliation glaucoma group. So is there again a difference between the two? So difference between the pseudoexfoliation syndrome group and the glaucoma group was not significant, but comparing to the control subjects, it was significant. So it may not necessarily be the causative cause of glaucoma per se.
But next time when you present, you have to show the p-value, because every place you just show the difference, means this is how much here, how much there, but unless until anything less or more, it will not have some significance unless it will be evaluated by a particular set of statistical tests. So whether these increase or decrease may be significant or may not significant, you have to do some statistical test on it and find out whatever the things are related to this or whatever things not related to this.
Sure.
Anything else? Anyone of this session left? Any presenter? So thank you everyone. We are going to conclude the session. Thank you, Dr. Sonam. AV team, kindly collect the mark sheets from the judges. You presented very well. Always make a PowerPoint which is visible. Don't use too much color or graphics which is not related to your own study. PowerPoint presentation hardly includes 6 or 7 lines, and it will be, if the background is black, then write it out white. Our best is on the white background. There is no need of so much fancy colors, means your name is with green, college address with red, and anything. As simple as good. And second thing, always see your PowerPoint on the presentation mode. Means whatever you are writing, if you are making a table, then your data are visible or not. Next time onwards, whenever you present, you will take care of these things. Means using how to make a good PowerPoints. There are a lot of study material is there, thesis is there, even lot of online resources are there. But always highlight your own photographs, own presentation in a better way. Thank you. Come here for the